Hey, hello, my name is Michael Lichternberg from Arnsberg. I'm here with Professor Marianne Brodmann from Graz. Hello, Marianne.
Hello. So we are here at LINC together, 2019, and discussing about identifying dissection. And I guess, Michael, it's a proper question. How do you do that at your institution in Arnsberg during an endovascular procedure?
Yeah, very good question. I think also a very important question. Dissections matters our endovascular approach and also the outcome of the endovascular treatment. And in the SFA and popliteal artery, of course, we can do angios with multiple angulations and check if there are haemodynamic relevant dissections. Below the knee, it's actually a little bit more different and difficult also. We have a bony overlap and we have tiny vessels, so it's difficult. And what we personally do, especially below the knee, we use quite often IVUS.
And if you have identified a dissection, so I guess you will not treat every kind of dissection. So what makes you treating a dissection and how do you treat this?
Yeah, we usually stick to the rule that if we have a haemodynamic impairment of flow caused by a section, then we go for treatment of that dissection, whatever that is. We have some data already published that severe dissections impairs also the outcome. Yeah? Kobayashi, for instance, he made a great paper on the evidence of severe dissections that this impairs patency rate. So definitely we need to classify if there's a haemodynamic impact of flow.
We have right now a completely new tool in our hands, and that's the Tack system. We both have experience from studies and from real-world experience. You use it right now in your real-world patients at your institution. So when would you use or when would you think that a Tack is an appropriate vessel dissection treatment option?
Yeah. It depends a little bit on the lesion which we have as an underlying cause. If we have severe calcification, the Tack system, of course, it's not the best way to treat this local problem. But if we have flaps, if we have some fibrotic, restenotic dissections, then we can definitely go with Tack implantation. And these Tacks on the 6F system work very well. You can precisely implant them, usually on an overlay or roadmap technique or with a ruler, so you can really precise it wherever you need it. Below the knee, and this is something unique, I would say, you have a 4 French system available with 4 Tacks. And also here it is really nice to implant these Tacks precisely where you want to have it. And I personally believe that especially below the knee, dissections impact outcome very much. So this is a great tool there actually.
Okay. So what is the final question? What is your best reason to implant the Tack?
So if I see a sticky flow, meaning that I have a haemodynamic impact, I definitely think of the option to use a Tack.